So welcome and thank you everyone for joining the Heart and Stroke Foundation webinar in collaboration with HeartLife Foundation. Today's webinar is titled, It's Not Normal to be Breathless. Know the signs and symptoms of heart failure, act now and live longer. Heart and Stroke and HeartLife are working to increase awareness, support, and advocate to ensure people living with heart failure receive the best care and treatment across Canada. To help build on this awareness, we want to acknowledge this very important week as it is Heart Failure Awareness Week. My name is Shannon Doucette, and I am the Heart Failure Project Lead at Heart and Stroke Foundation, and I will be one of today's moderators. I am honored and have the pleasure to introduce you to our second moderator, Marc Bains, co-founder of the HeartLife Foundation. When you join today's webinar, you will be joined through a computer audio. If you prefer to listen with your phone, simply select phone call or select call me and follow the prompts for more options. Questions are welcomed during today's webinar. Please feel free to enter them through the question panel and they will be addressed during our Q&A period at the end of the webinar. Lastly, the webinar today will be recorded and available on the following list of websites you see in front. So today, we would like to begin by acknowledging the Indigenous peoples of the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call these lands home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We're gathered today because of a shared commitment to equity, including health equity and reconciliation. I encourage you to reflect on what that means for you and your work and in your lives. The objectives of this webinar today are to really describe the early signs and symptoms of heart failure, to discuss strategies and tools for primary healthcare professionals to recognize and the diagnosis of heart failure, to gain perspective on the heart failure journey from a person living with heart failure, and lastly, to discuss opportunities to improve health outcomes through a better understanding of warning signs and early diagnosis within the community. To begin our webinar now, we would first like to start with an interactive polling questionnaire. The first question, the polling questionnaire should be displayed on your device, and please feel free to participate by choosing the most correct answer. The first question that we have is, what is heart failure? A chronic condition caused by the heart not functioning as it should or by a problem with its structure. B, when the heart is pumping not enough blood for your body's needs. C, when the heart is too weak or too stiff, or D, all of the above. I'll just wait for your answers. And yes, the correct answer is all of the above. So our second question that we have now is, what are the most common causes of heart failure? A, coronary artery disease, B, high blood pressure, C, diabetes, or D, all of the above. We'll just wait for the correct answer. And most say all of the above. Yes, so all of the above is the correct answer. And question number 3. When should you pay attention, use caution, and check in with your healthcare provider? A, when there is weight gain more than 5 pounds in a week. B, when you experience worsening shortness of breath. C, when you have noticed an increase of swelling in your legs, ankles, feet, or abdomen. D, when you've experienced an increased amount of fatigue. Or E, all of the above. And the correct answer is yes, everyone, 100%, all of the above, correct. And our last final question of our polling questionnaire is, which one is not a self-management skill or strategy when managing heart failure? A, daily weight, B, monitoring salt intake, C, smoking, D, monitoring fluid intake, and E, medication adherence. And our final question and answer is smoking is the most common, yes, is the answer. So thank you everyone for participating in our polling questionnaire, and we hope that you can continue to expand your knowledge and as we move on forward into our webinar. Now I would like to introduce you to our second moderator, and that's Marc Bains.
Thank you so much, Shannon. Well, the questions almost had a theme to it at the beginning, all of the above, and then you threw one for the loop with everyone, I think. So I appreciate all of that, and really honored to be here, and looking forward to our amazing speakers who I'm so honored to introduce today. Our first speaker, or two of our speakers, our first will be Bonnie Catlin, but we also have Sunny Tutt as well. Sunny Tutt is a personal lived experience of heart failure, a heart transplant recipient. He's a patient partner on the Canadian Medical Association board and HeartLife champion for organ donation. Sunny was diagnosed with heart failure at 18. He's now living his new lease on life. He's a personal friend of mine. I've known him for a long time, and he continues to inspire me with everything that he does. He's really living his new lease on life since his transplant in 2014. When he's not working in construction and building amazing homes, he peer mentors other individuals with lived experience, supports organ donation across the country, and continues to advocate for better care. Our second speaker, another friend and colleague, Bonnie Catlin. Bonnie Catlin was a nurse for almost 38 years. She still looks like she's 20, so I'm not sure how she gets away with it. She had a focus on cardiology. In her current role, she's a regional director for clinical education, nursing, and allied and regional professional practice at Vancouver Coastal Health. And her previous role, she was provincial heart failure clinical nurse specialist and provincial clinical director of heart failure with Cardiac Services BC. I've known Bonnie for years, and she is both a caregiver, a healthcare professional, and passionate advocate. And we look forward to speaking with both of them and learning about what they're going to teach us. Right now, we're going to talk about exploring the journey from heart failure diagnosis, beginning with the healthcare provider experience through Bonnie and her perspective. So without further ado, Bonnie, I'm going to pass it on to you.
Thanks, Mark. Welcome, everybody. And it's morning for me, but afternoon for others across the country. But just want to say I have no conflict of interest. And this is going to be sort of the outline for the session for today. We're going to talk about heart failure, diagnosis, and treatment. So next slide. So what is heart failure? As you all know, it's a chronic progressive condition, and that at times it's got really high symptom burden. It occurs when the heart is not able to eject blood properly or efficiently, or fill properly or efficiently. And then what happens is it inhibits a bit the ability of the heart really to meet the demands of the body. There's no cure, but you can live a quality of life you deserve if you manage your heart failure well. And you'll do that in conjunction with your healthcare providers too. So we have two main types of heart failure. I know there's 4 types, but these are the 2 main types. There's heart failure with reduced ejection fraction, where it's a big floppy heart and the ejection fraction is less than 40%. And it's probably one of the most commonest heart failure out there. And it's just a really weak pump. Heart failure with preserved ejection fraction, it's stiff ventricles. It's very different than reduced. The ejection fraction is usually greater than 40%. And the heart has a lot of problems with relaxing because of the thick walls. But, and then what happens is ventricles are stiff. The area within the ventricle is smaller than what it should be. When it ejects it out, it's not enough blood. Next slide. So some of the causes of heart failure are hypertension, ischemia, from a heart attack and multiple other reasons, valvular disease. Some patients have a family history of heart disease, arrhythmias, some endocrine disorders like diabetes and thyroid, obesity, infection, pregnancy. Some are idiopathic. We really don't know why we got heart failure. And some theoretically can be drug and alcohol induced. Some big risk factors, and we're not going to talk a lot about prevention, but I think we should mention risk factors: smoking, drinking, not exercising, not eating well. You really have to be making really good lifestyle choices around the risk factors for sure. Slide. Some of the symptoms, and I'm sure a lot of the patients on the call have experienced a lot of these. Shortness of breath. We should not be short of breath. It's not a good thing, but when you go into heart failure, you do become short of breath. You're very fatigued. You lack energy. You get swelling in areas that you normally wouldn't get swelling: your ankles, your feet, your legs, your abdomen. Other symptoms could be hypotension, hypertension, pulmonary congestion, like you're coughing, having trouble breathing, shortness of breath. You're sleeping with more pillows. You're finding that you just can't get your breath when you lie down to go to sleep. Can't do your regular exercise. There's a lot of exercise intolerance. Like I said, fatigue and venous congestion. Some of the providers on the line will also notice that you get increased JVP. Patients and providers can also notice that your weight's going up, which is not good. Anorexia, nausea, vomiting, your gut's just not feeling right. As it progresses, and if it's getting into really more GI symptoms, you can get ascites, you can get liver congestion, and like I said, you can get pedal leg and also sacral edema. Next slide. These are just some of the things that we really need to think about and are red flags that the providers as well as the patients can think about as to when to call 911 or when to consult your GP or your NP. Not everybody can check their blood pressure at home, but if you can and you notice that it's low and you're actually symptomatic, like you're feeling nauseous, dizzy, like you're going to pass out, if you can get access to a SAT monitor and it's low, if your heart rate's high, if you have new onset of changing in the coloring of your skin, you need to get to your GP or contact your NP fairly quickly. And if you're getting really bad, you need to call 911 and get to the hospital and get properly diagnosed and treated. Next slide. So this is a great resource that Cardiac Services BC did in collaboration with our Heart and Stroke Foundation, and we call it the Heart Zones. And it's basically a resource that all of our patients should be using on a daily basis, and it should actually sit up. We recommend that it gets put up on the fridge, and it just walks through what you as a heart failure patient needs to do on a daily basis around weighing yourself, watching your fluid, taking your medications, eating proper salt-free food, and then also balancing your activity and exercise. As you go down the heart zones, if you're in the green zone, that's good. If you start to have symptoms, it outlines what are caution symptoms that you need to start worrying about. And then if you get into the red zone, that's not good, because then it's really telling you that you need to call 911 and you need to get to a healthcare professional to help you and support you and get you out of your exacerbation. So as you know, confirming diagnosis is really important with our heart failure patients. It's done in basically 4 ways. And if you have access to a little bit more sophisticated diagnostics, and if you're not in a remote and rural area, there's a couple other things that you can also do. Most of our patients that are diagnosed actually are diagnosed in the emergency department or in the GP's office, but mainly the emergency department. So they usually do have access to a fair amount of diagnostics. The physical assessment is really important. And it's, remember, because it's a clinical diagnosis for heart failure. And usually if a patient presents in the ED, or if they present in your office and you've done a physical assessment, it really can be your preliminary diagnosis. You've got blood tests that you can do, you've got chest x-rays, you've got an echo and a nuclear scans that you can do. And I'll speak a little bit more detail in them. Next slide. So with the self-assessment, what you really want to look at is, from a neurological perspective, how's their memory gotten worse? Do they have an unsteady gait? You need to ask your patients all these questions, and you as a patient need to really understand this and do a self-assessment. Are they getting headaches? Are their headaches getting worse? From a respiratory perspective, because being short of breath is not normal, being breathless is not normal, you need to assess, are your patients short of breath? Is their shortness of breath worsening? Are they using more pillows to sleep at night? Does it appear that they are labored since they've come to see you in your office? Are they using their intercostal muscles? Take your stethoscope, auscultate their lungs. Do you hear crackles? If you have access to a SAT monitor, are their SATs dropping? From a circulation perspective, you can do blood pressure, pulse. You need to check their edema. Do they have worsening or new edema in their legs, ankles, feet, stomach? Or you can ask your patients, are your slippers tighter? Are you having to loosen your belt a little bit? Are your socks tighter? You can do an abdominal girth and also compare that to the last visit. GIGU, you can ask about nausea, vomiting. Like I said, check their abdominal girth. How are they peeing? Are they having good output? What color is their output? Is it concentrated? Are they constipated? Look at their skin. What is the color of their skin? Has it changed since the last visit? Are the extremities more cyanotic? Do you notice mottling in the extremities? What's the skin turgor like? And do they have any open sores? On the right-hand side of the slide is an assessment tool that we use within our heart function clinics in BC, and it guides the healthcare provider through what to look for and what to assess when it comes to doing the full head-to-toe assessment on your patients. So it's a great guide, and I do believe it's on Cardiac Services BC's website. So one thing that you also want to look at is the New York Heart Functional Class of your patients, and this can be assessed on their initial diagnosis and then as they come in. And it's basically how you can track a patient and how their heart failure gets better or gets worse. Most of the clinical trials that we do do look at improving New York Heart Association functional class. And then if you look at this slide, and I'm not going to speak to it in detail, it does give you recommendations on make sure the patient's on medication, self-management, make sure at some point you can look at heart devices, and at some point you can look at the bigger procedures like surgery, transplant, and then if they're at end of life, you can look at supportive care and palliative care. Survival at 1 year, if you're a class, it's greater than 95%. So we want to get our patients as best as we can more towards that. One of the diagnostic tests that you can look at to either confirm diagnosis or rule out whether or not it's cardiac or not, because there's other reasons why these biomarkers can go up, are two specific biomarkers, BNP and NT-proBNP. And depending on the province that you live in, some provinces will fund BNP, some will not fund NT-proBNP. But what they are is they're naturally occurring amino acids in the body. They are released from the heart into the bloodstream when your heart is under stress. And it's a simple blood test. For BNP, it's important that the BNP is below 100. And usually if it's above 100 and getting closer to 400, it's pretty much a positive diagnosis for heart failure. With the NT-proBNP, this one patients use, or this one some providers use because it's a little bit more sensitive. It stays in the body almost up to 120 minutes. and not a lot of coverage for this in some of the provinces. The flag for this is if it's over 400, there is a likelihood that it is definitely heart failure. It is also depending on the patient's age, it can be higher and lower depending on their age. Acute heart failure, sometimes in acute heart failure, the BNP can be up for multiple other reasons. Could be because you've got bad kidneys, because you're septic, pulmonary embolism. For chronic heart failure patients, it can be because of COPD, it can be because of atrial fib. So you got to think about all this stuff. Next slide.
Bonnie, just another minute, Bonnie. Sorry.
Okay. Oh, this is lab tests. If you have heart failure, I'm not going to go into this in detail. You can actually have changes in your lab test because of that. This is a quick picture of a patient that has heart failure from an X-ray. Just remember, the size of the heart should be at least a third of the space. So this person definitely has heart failure. Next slide. Like I spoke a bit too about the echo, it will give you EF. It'll show how your heart is thick or floppy for preserved or reduced ejection fraction. And then if you have access to nuclear scans, you can do a MUGA or a MIBI. They work both. They work a little bit different, but they do definitely measure your ejection fraction. Some pieces, the MUGA will do your wall motion mechanics. So they give you a little bit more of a detailed piece around diagnosis. A lot of times health authorities or hospitals will have quicker access to nuclear cardiology as opposed to echo. I know in BC we have large echo wait times. And next slide. So I'm going to pass it over to Sunny, and he's going to speak to his journey to diagnosis. And over to Sunny.
Thank you, Bonnie. Again, my name is Sunny Tutt, and I'm happy to be here today to share my lived experience with you all. So I have no conflicts at all. Initial symptoms prior to my diagnosis. So it all started with flu-like symptoms, and I call it the flu that changed my life. These symptoms progressed into severe fatigue, just feeling tired all the time, unable to do much activity. And with activity, I had breathlessness, even at rest. It got to a point where I was constantly coughing up. I had a wet cough, and I didn't know at the time, but it was from fluid retention that was happening in my body. And then that water retention was causing my lower extremities, my abdomen, and my ankles to be bloating. And so there was obviously signs of swelling happening. I even had difficulty laying on any flat surface. I would need to have many pillows propped up behind just to be able to relax somewhat. And even to the point where I needed to be on a recliner. It just felt like heavy pressure on my chest, like the illustration here on the slide. And also I had heart palpitations happening, and random flutters happening of the heart, and dizziness and lightheadedness, getting up from a seated position or feeling even faint at times. All these symptoms I just have mentioned, they were happening 20 years ago, only at the age of 18, just being a teenager. Journey to my diagnosis. I created a table to simplify and better describe my journey. And as you can see, I have the event, the action taken, and then the diagnosis with the end result. So again, I had the flu symptoms that went over a course of a few days. And as usual with any flu I've had in the past, I went to go see my GP, diagnosed me with flu, possibly pneumonia, and just prescribed me the antibiotics. And they were antibiotics that I've taken many times before in my life. Unfortunately, the symptoms just kept worsening, hoping to get better, but I waited for the meds to work. Unfortunately, there was no change, and the symptoms I mentioned just began to get more severe. My first hospital visit was a visit to the ER late at night, between 2 and 3 a.m., unable to sleep, many pillows propped up, feeling bloated. Made a visit, and they just did an assessment there and said that I have pneumonia, and prescribed me stronger antibiotics that would combat the pneumonia. And after that, I had subsequent hospital visits when I had no change and my symptoms were getting worse at home. And again, in the middle of the night, visits 2 and 3 consecutive nights, I went to go visit the hospital, and the ER doctors, the hospital staff just said to continue antibiotics and let it take and see, let it do its course. And I explained to them that how I had a heavy chest and it felt like I was like drowning in myself and had like a big air bubble in my chest and I just can't get comfortable. And it got to a point where they said, okay, maybe you have gas, take antacids. And here I'm buying Tums and chewing Tums like candy at home to, you know, reduce the symptoms, but there's no change. And on my third visit, I even mentioned that just there's no change. And it got to a point where they questioned me, assumed I was taking maybe recreational drugs, asked me I was taking steroids because I was in competitive football. And I told them that I had not even touched a cigarette, no drinking, and heck, I'm not even legal. I was 18 at the time, just a teenager. Finally, my 4th hospital visit, and it got to a point where I hadn't slept properly in over a week and a half. I'm just struggling, can't move. And with the aid of my father, my parents, I pleaded to them at home that I'm like, something is really wrong. At this point, I'm in tears, I can't breathe. My father went with me to the hospital, and with his assistance, he had to take a more persistent and aggressive approach with the staff and really push for further testing. And so they took me to the children's ward where they had no beds in this hospital at the time. And I've got my 6 feet tall, 18 long legs dangling off the bed, and finally order a full round of tests, thorough blood work, and now an x-ray. Finally, the x-ray happens, and then they see that my heart is almost double its size and it's enlarged. And then they've given me the informal diagnosis of having heart failure. I'm hospitalized and I'm on the road to leading to my official diagnosis. They stabilize me. I take some basic heart medications. They diurese me with Lasix, take off plenty of fluid. And then a few days later, I was arranged to be taken to St. Paul's Hospital via ambulance transport for various testing, which included an ECG, echocardiogram, and an angiogram. And then St. Paul's Hospital had sent an official diagnosis of viral dilated cardiomyopathy, in which the heart muscle is inflamed to almost more than double its size, and I lost all efficiency of the heart, and my ejection fraction was below 20%. And just to reflect on my diagnosis. So basically, the path of diagnosis had much more resistance, unfortunately. And it was mainly due to the fact that I was so young, my own GP, walk-in clinics, and ER doctors and staff just didn't think that I could have something so comprehensive. So unfortunately, they just assumed it was other things. And although I wished it went very straightforward, like the illustration below, it didn't. This occurred over roughly a 2-week timeline after my first visit with the GP. Hearing this diagnosis of heart failure was definitely very shocking. The word heart failure, the term heart failure diagnosis just sounds so intimidating and overwhelming. At that time, being 18, I definitely had a low health literacy for something of this complex and comprehensive and so intimidating. And I think to myself now, what could I have done different? But I guess there really isn't. And eventually, I was welcomed under the care of St. Paul's heart function clinic, and on my way to managing this heart failure. Lessons that I would like to share from this experience of diagnosis is the need. I would urge people and patients like myself to be more accountable for your own health and advocate for yourself. Be persistent, ask questions, and sometimes I think I wish I was more persistent and aggressive. If I take that knowledge I had now to then, I wish I was more confident and I confronted them and told them to test me more. And I think it's important to just read your own body. You know your own temperature, you know your own body, and you should be able to ask them all the questions they need to. And there are no dumb questions. Nothing is too minor to bring up to your healthcare team. And I'd like to just generally stress the importance of getting to know your healthcare team. This will allow you to approach them with questions during and even after appointments. Sometimes I wish back then that I had taken, even when I had the previous visits in the ER, that I'd maybe taken the ER doctors their cards or the email and may have contacted them the day after if there was no change, and just maybe had the opportunity to follow up. And so it's important to be able to contact them, communicate with them, and bring up your concerns and questions that may come up in your daily life at home. So again, important to reach out to your healthcare professionals immediately. And again, my diagnosis experience, having the right healthcare team after diagnosis is important. So I went from a Surrey-based cardiologist, eventually under the care of the Heart Function Clinic at St. Paul's. And it was beneficial to me, especially since they're equipped with, you know, all the facilities and tech for thorough testing, for implementing major surgeries and even heart transplant. And and being around a well-experienced, well-rounded healthcare team for my care. And fortunately, I was near a metropolitan area versus a rural area to be near this major hospital. I'd also like to stress the importance of support from caregivers. At that time, I had my family and specifically my parents to aid me, and support during these times is so crucial, especially while being so vulnerable. And like myself, I had like low health literacy for something so complex, and definitely was going through some mental health issues at the time, hearing this and having issues of acceptance and just denial with this. And so having someone just in general with you, any friends and family, to help you to understand, ask any questions during these appointments, especially when so much information is going back and forth, is very, very important. And understanding the diagnosis itself, understand and accepting this change in your circumstance. The sooner you understand the diagnosis and what's required with your new medications, lifestyle, and to manage your health, the quicker you can go on to better manage your heart failure and achieve the quality of life you deserve.
Thank you so much, Sunny and Bonnie. I appreciate you sharing your perspectives of the journey of the heart failure diagnosis. But then what's next? And so just as important, we want to explore the management of heart failure after diagnosis and what it looks like really living with heart failure, and what that journey is on those next steps. So now I'm going to pass it on to Bonnie to shine a light on the primary care provider's perspective of heart failure management. Bonnie, back to you.
Thanks, Mark. So two big pieces around managing and treating heart failure for the providers is we really stress with our patients, and the providers need to also do that around self-management. And I'm going to speak to some of the tools, and then treatment and management, I'll speak briefly to medications and devices. Next slide. So the four main pieces around self-management for our patients are daily weights, salt intake, fluid, and activity. So daily weights, we really recommend that the patients weigh themselves every day. They do it first thing in the morning when they wake up. They use the same scale and they wear the same clothes. What's critical for them to really look at is to report any weight gain that is around 4 pounds in 2 days or 5 pounds in a week. That is so important. Salt intake is also a big piece around self-management. I know there's a lot of discussion around salt and whether or not we should be restricting it. We do recommend it to be restricted at less than 200 milligrams. And what's interesting is your thumb, the end of your thumb, that's 2,300 milligrams of salt. So if that gives you some context about how little salt 2,000 milligrams is, and really how difficult it is to keep your salt low. There has been some clinical trials that were done, specifically the sodium HF trial that was led by Dr. Justin Izakowicz out of the Edmonton Mazikowski Center. And we were really hoping that we could pin down what is the appropriate salt restriction. His trial looked at 1,500 milligrams. It was a neutral trial, so we didn't get out of it really what we needed, but some exciting stuff that did come out of it was that it restricting salt to 1,500 milligrams and have dietitians following patients, it actually improved the patient's quality of life and New York Heart Functional Class. So that is a good thing. I know Justin's going to be doing some more secondary analysis around salt, so more to come with that. Fluid restriction is also one thing. As you know, more fluid in the body, harder for the heart to pump. We recommend 6 to 8 cups per day max. Not all patients have fluid restrictions, so that's something that you need to talk to your provider about as to whether or not you need to have a fluid restriction. Fluid is anything that's room temperature, is liquid at room temperature. And that can be almost anything that you put into your mouth, like soups, coffee, a lot of fruits, ice cream, unfortunately. And some tips to reducing your fluid is you can wear chapstick, brush your teeth, chew ice chips, but be careful of that. And you really can chew gum and have frozen fruit. That helps too. Physical activity or exercise. I did touch on this a little bit on how important it is to keep active. It makes your heart stronger. If some patients can only do a bit of activity and progress just walking from their bedroom to the bathroom and they improve it every day, that's good. Some patients are at a point where they can actually do exercise and go for longer walks. They can run, they can bike, and it's just improving that and keeping that up. One thing to really remember as a heart failure patient is if you've overdone it, you will know it because you will be very tired the next day. And when you're exercising, you should still be able to speak. Medications and treatment, I'll speak to a little bit down the road on a couple other slides. So these are some of the Heart and Stroke Foundation resources that are on their website. They're excellent resources. They have a full booklet around living well with heart failure, all the self-management, self-monitoring pieces that you can tap into. They've got resources for patients on daily weights, sodium, fluid. They've got the heart zones. All of these really, really help the patient self-manage. Like Sunny said, managing your mental health is so important with heart failure. 33% of our heart failure patients actually have depression. It is quite high. Depression or anxiety and suffer from stress. Our caregivers have really high burnout, so we have to be very careful about that. We've got great resources on the Heart and Stroke website that talk about how to deal with stress, anxiety, depression. What do you do when you're traveling, when you have heart failure? How can you care for the caregivers? And there's pieces around also herbal meds, and that's important too. Next slide. So we've got cornerstone medication that all of our heart failure patients should be on. And it starts with the beta blockers. We've got ACE and ARBs, and the new one on the block is ARNI. It works a little bit different. It's a little bit more of a powerhouse. We've got MRAs that have been around for a long time. And then we've got SGLT2 inhibitors. So beta blockers, most of our cardiac patients are on beta blockers. There's a wide range of beta blockers that you can be on. It just depends. Most patients are on bisoprolol or carvedilol. Just remember, they drop your blood pressure and they will lower your heart rate. So you really got to watch your patient for those symptoms. For the ACE and ARB, they will also drop your blood pressure. They help your heart, also prevent remodeling. And they do affect your kidneys, so you have to really watch the kidneys. The ARNI is a combination of an ARB and a neprilysin inhibitor, sacubitril. So it's got a double whammy. Just remember if your patient is on an ARNI, you might have to decrease their diuretic because they actually do. It works a little bit like a diuretic. The MRAs have been around for a while. The eplerenone is the new one. The spironolactone has been here forever. Watch for hyperkalemia if you're a provider. It can cause dizziness and also lightheadedness, and it does affect your kidneys, so you really have to watch the kidneys. For a lot of these medications, you do have to watch the kidney function, so just remember that. The SGLT2 inhibitor originally was a trial with diabetic patients, and what they found is that cardiac patients actually did well on these. So we started doing some trials specifically targeting heart failure patients like DAPHF and EMPA-REG, and tried to figure out, do these truly help our heart failure patients? And they actually do. So this is one of the cornerstone medications that you should also have your patient on. A simple way how these work, I'm happy to go into the cellular stuff offline.
Bonnie, just about 30 more seconds, sorry.
Okay, but they basically prevent sugar from going into your blood. And as you know, sugar is bad when you have cardiovascular disease, and it makes it worse, which leads to everything else. Ivabradine is a medication that patients will go on if their heart rate is too high. And we have lots of good resources on that and lots of good information on that also on Heart and Stroke website. Other ones are diuretics. That's usually the one that you put your patient on right away when they present. So some device treatments, we've got pacemakers to speed the heart up. We've got defibrillators to slow it down. We've got the fancy heart failure pacemakers called CRT, where there's a few more leads in the heart and it makes sure that the patient's ventricles pump at the same time. We also have CardioMEMS, which was based on the Champion trial. It actually is a little Bluetooth device that goes into your pulmonary artery, and it actually detects heart failure quicker than what your blood or than what your weight would. So it's a really cool thing. It has to be inserted by a right heart cath. It's not necessarily approved in all the provinces are funded. Beyond that, there's also surgery to fix valves. There's angiograms to put in for revascularization. If your heart really needs a rest, they can put in a VAD. That's a big surgical procedure that is only done at certain big heart centers. And then finally, there's also transplant. So those are some just sort of high level, quick things that you can do for self-management and for treatment of our heart failure patients. And I'm going to hand it over to Sunny, and he's going to talk about how he manages his heart failure and how he lives well with heart failure.
Again, I have a table here to just show my journey and major procedures that I've had. So after being diagnosed in 2003, I was pretty manageable with medications. And up to 2008, I was finally diagnosed with atrial fibrillation, an arrhythmia of the heart and regular heartbeat. And so I was scheduled to get a pacemaker ICD CRT implant in 2008. And to combat the atrial fibrillation and deal with the arrhythmia issues I had and pace the heart. Unfortunately, it wasn't yielding the results. And so then I was scheduled afterwards in 2009, a year later, with a heart ablation procedure. And unfortunately, the heart ablation wasn't as successful as they expected. And so after that failed attempt, I was scheduled for an ICD upgrade in 2009, where they added an additional lead to help pace the heart better. And after that, I was pretty stable with the new medications that I was on, with medication management and being seen in clinic pretty regularly, and with the ICD, I was very manageable. However, by 2012, I noticed that there was obviously more hospital stays that I had to go in for minor heart failure issues and longer duration of stays. And in 2013, those stays got longer and longer, more reoccurring hospital visits from when heart failure episodes were happening. Lasix and other heart medications just weren't performing as expected, and just my bounce back rate after long hospitalizations were happening, it just wasn't there, to the point where, and finally in November and December of 2013, I believe it was my fifth hospitalization of the year. And I was in there for a month, and just the specific medication I mentioned called dimutamine was given to me via IV regularly in these visits to help boost the heart. And at this point, it was not boosting the heart. The doctors and all the healthcare professionals were telling me that that my organs were starting to shut down, my kidney function was not there anymore, and my creatinine levels were reaching into the low to mid 400s, to the point where I was told that I needed to get an LVAD. So in December 2013, I received my left ventricular assist device implant. The images here is that's just 2 days after receiving the LVAD in the hospital bed there. And then the image to the right is roughly 4 months after. You'll see the LVAD. I'm wearing it and a utility belt there. And then I have my fashionable bag with my backup controller and the batteries that I carry with me everywhere I went. And then 9 months after waiting on the transplant list, I finally got the call and received the gift of life. My transplant in July of 2014 was successful, and went on to improve my quality of life vastly. I was now getting into building homes. I was working full-time, studying part-time, and there's a vast change in my condition. And in early 2017, while exercising and doing my regular activity and regimens, I noticed that I was feeling similar heart failure symptoms as before. And I just assumed, and I just have difficulty, and I wasn't on the treadmill. And I just thought, you know what, maybe I have more fluid on board or something. I took more Lasix, and the problem continued. I just couldn't perform the regular activity level I could on the cardio machines at the gym. And so I contacted my clinic, and after some further testing and having a biopsy done and tested rejection, they yielded a result of having antibody-mediated rejection, where I had my white blood cells were attacking my new heart, unfortunately. So after getting treatment for that, I was pretty much stable, on with having my annual visits and assessments of my heart every year. And I've been very stable since 2017. But unfortunately, up until my annual just last year in November, I wasn't aware of it, but I was, after having an ECG, the doctors all told me that I now diagnosed atrial fibrillation in my new heart in 2022 in November. And so after that, I've had a biopsy, angiogram. I have no rejection of the heart. There's no other issues with it. Unfortunately, there is this arrhythmia issue now. And so I have a cardioversion scheduled later this month now, and hopefully that can zap me back into sinus rhythm. Managing my heart failure. So the challenges I had at the beginning, I had since I was 18, and just initially having that shock and difficulty having acceptance and being in denial. I was having difficulty during this new lifestyle. And so having my mental health severely affected, it was difficult getting into this regimen, taking medications on time, and taking the instructions seriously, and being part of appointments. These important daily regimens include the daily weights, especially if you're on diuretics and Lasix, taking medications as prescribed and on time, the importance of having a healthy lifestyle, regular exercise, and activity. And the healthy heart diet. Diet is, if not more crucial than the activity portion. Following your fluid restrictions if you're on Lasix and diuretics, and also low sodium diet. And just some tips. Giving up salt and going on low sodium is difficult, so seeking salt alternatives is helpful. Importance of reading all labels and food packaging when grocery shopping. All of this contributes to having a better healthy heart diet. So St. Paul's Hospital and the Heart Function Clinic, they had a cardiac rehab program that I attended, and it's helpful to aid patients to get going on a fitness routine. And so, and I'm sure other outpatient clinics have similar programs. I attended a rehab clinic after my diagnosis, and after receiving my LVAD, and even after transplant, and when I had any other long hospital stays, just to get me back onto a fitness routine and help guide me and just help me warm up to that. I was also offered appointments with a dietitian to help arrange meal plans and just general tips almost annually with my annual checkups. And even if I needed help, I could seek that myself and contact them via email, and they're always happy to help with meal plans. I couldn't stress the importance of meeting with pharmacists, especially when new medications are being introduced. They can go over the best times to take your medications, what to watch out for, any symptoms and side effects to watch out for while you're on these medications. And I found that very valuable. Compliance is so important for your heart failure management. Attending all appointments, following instructions by the healthcare team, and taking the medications and just following the regimen is so crucial. I at the beginning, 18, I wasn't taking these things seriously. And so I I can't stress the importance of it, especially if your effort and choice lifestyle and overall compliance is vital to even qualifying for your transplant qualification, or even any treatment that you need to receive related to heart failure or any other surgeries. Doctors want to verify your commitment to the program, because if you're not taking it seriously, they won't either. And so these are stressed to me even towards my transplant workup before transplant to get on the list. It's very important to be compliant. So the mental.
Hey, Sunny, sorry, just a couple more minutes.
Sure. Okay. Thank you. Just want to go over the mental health aspect. With my personal experience, I just want to stress that the mental health component is just as important as your physical health. I would stress to reach out to your healthcare team if you need any of that assistance. After my diagnosis and like I stressed, I had difficulty adhering to the new lifestyle and everything, and it had a lot to do with the mental health and my emotional issues that I'm having. I didn't speak up, but also in that time in the early 2000s, it wasn't really mentioned or brought up in clinic and discussed. And I wish I spoke up at that time and asked for it. But my healthcare team really took like a harsh facts and realities approach when it came to my appointments and prescribing things, and just telling me how things are, and very fact-based. And doctors were very analytical, and some would take the tough love approach, and to the point where I would just hear things like, oh, your heart is no good, you need to get on the track here, or your heart is garbage, you'll need a new heart. And it wasn't definitely helpful. And there was no sense of community as well. Being a younger patient, I was in the clinic, and most patients there were elder, and I really couldn't connect with anybody, which made it very difficult. And I couldn't just communicate with someone to share my problems with. And it's always helpful to have peer-to-peer contact. Eventually visits to a psychologist via pre-heart transplant clinic helped me coping. And it was introduced to me in 2008, 5 years after, and helped guide me through all the difficult times where I had to travel through the journey with LVAD and transplant. Peer-to-peer support and resources is something important I wish to stress. Before my LVAD and transplant, I met with other LVAD and transplant patients and recipients, and it was arranged by my clinic, transplant clinic. And I can't tell you how much it had an effect on me. Seeing live other patients that have a successful LVAD implant or a transplant just gave me so much more confidence going into them. And just having that peer-to-peer support then was so helpful. And even now, there's Facebook groups hosted and moderated by my outpatient clinic at St. Paul's. HeartLife Foundation has a Facebook group, and even Wednesday virtual hangouts where heart failure patients can get together and talk and share their wins, challenges, and share tips and tricks. And also want to say that the HeartLife Academy has 3 courses available as well. And Heart Failure 101, Heart Failure Meds, and Mental Health, Finding Your Own New Normal. It's for patients, by patients, backed by science. It brings together person's lived experience and health. Life after transplant. Just wanted to share some images of my personal life after transplant. That is a photo on the left of me 2 or 3 days after receiving my transplant. Image there of my wife and I going to look at my heart, and you can just see how big it is. It's almost the size of like a turkey there, and the LVAD is still in there. And then a picture of us on the day of our wedding, and just some accomplishments I have. That's me where I built my first house and put it on the market. And the other picture there, I just completed my first transplant run of a 7-kilometer run 8 months after transplant. And then just a picture of me speaking at a conference in Montreal regarding my lived experience as a patient. And just wanted to close off really quick here. Not to discourage anyone, but heart failure patients, including myself, you got to remember that you will have good and bad days. Not every day will be the same, just like this illustration below. With the right tools and resources, you can live the quality of life you deserve.
Well, thank you both so much for that. I mean, such insightful experiences in conversation. I think this probably could have been a webinar that we went on for 2 hours. Just with the amount of knowledge, Bonnie, from your end, and sharing that to improve diagnosis and management, and Sunny, that lived experience perspective I mean, the flu that changed my life. That's a powerful statement, right? You don't think things like that. And then incorporating that mental health aspect of it. A lot of the times we think about heart failure as a physical challenge and burden, but you don't think about that mental health aspect for both patients and caregivers. So appreciate both of your insights on that. We did want to leave a few minutes for question and answer, because I think that's important. And we have a few in the chat that were sent to us as well. One of the first ones is my cardiologist can't figure out why I have CHF. What should I do to find out? And I think this is a question for both Bonnie and Sunny from an advocacy perspective, but also maybe from a diagnostic perspective. So maybe Bonnie, I'll start with you, and then Sunny, you can jump in after.
So I'm assuming the patient has been diagnosed with heart failure, but wants to know what caused it.
Correct.
Sometimes we don't know, and that's called idiopathic. And run all the tests, don't have any of the risk factors, like everything. And Jillian and Mark are a perfect example. Well, actually, Jillian in the beginning was idiopathic, and then they just couldn't figure out why. But then I think it moved to, it probably was viral. And Mark, wasn't that the same with you? That it was idiopathic?
Idiopathic.
Yeah. And it's frustrating for the patient. It's frustrating for the provider. But I think the most important thing is that it gets treated, and the patients get on the right medication. They start doing the proper self-management and move along with their condition and live as well as they can with their condition.
Thank you, Bonnie. Sunny, any thoughts from an advocacy perspective?
Well, I had similar experience at the beginning. I couldn't get a straight answer, and that's why they labeled it viral dilated cardiomyopathy, right? Viral, yeah. They just don't know why they called it viral. But I mean, we had our own hypothesis of it because I had another relative at the time that also had it in my family. And we just got lucky because after my LVAD and transplant, and the transplant clinic somehow managed to send a sample of my heart to get tested, and we were luckily able to find out that there was a genetic mutation. And so they got to the point where the pathologists and all the labs, they were able to figure out what genetic mutation it is, and we just got lucky. So it just depends on the circumstance if you can get a second opinion or anybody else can maybe see, but sometimes you just don't know, unfortunately.
Yeah. No, thank you for that. And to an extent, as we educate ourselves more, we're empowered and become our own advocates, and and we have support around us to advocate for us. So that's always important. Sunny, a question came in for you. Sunny referred to mental health support, and I'm wondering if his wife also received support.
Yes. So in the clinic, mental health support was made available to all my family, including my wife at that time. So we did speak to our psychologist together, and I had the brunt of all the visits because I was affected most of it, especially during the times of transplant and LVAD. When we were being told I needed an LVAD, that's a time where we would all meet with a psychologist, or even just the nurses or even doctors would meet us all and just give us more information. And as a collective, just ask questions and get answers. And even when we met with our other patients who received them, we all met with them together. And I found it very helpful for all of us to do it together as one.
I appreciate that. Another question came in, and I have a little bit of knowledge around this, so I'll take it first, and then Bonnie or Sunny, you can jump in, is how patients can be tested for genetic causes. And so because my cardiomyopathy was idiopathic, I thought maybe it's genetic. So we did some early genetic testing with minimal markers. And just recently, over the last 6 months, had a referral from my heart failure specialist to the genetic counseling department through Vancouver Coastal Health, where we're doing additional tests. So for me, it was going to my heart failure specialist and cardiologist saying, I would like to do more genetic testing, and then get a referral to the genetics counseling department. Bonnie, I don't know if you want to add anything to that, but that was kind of the path that I was told how it happens.
Yeah, no, you're right, Mark. And from a genetics perspective, we've definitely moved beyond. Bonnie's dad had coronary artery disease and heart failure, so she might get it. We actually can do very detailed cellular chemical genetic testing now. And They have a big genetic clinic out of, I believe it's either St. Paul's or VGH in Vancouver, and they do a lot of genetic testing now.
Okay, perfect. And maybe we'll just do one last question. And this presentation will be available after. And if there's other further questions, you can send them out to us and we can share them with our speakers and get back to some answers. But I think this is a key question, just because that point at diagnosis is so critical to the next stage of living with heart failure. So what are the things a person can do for self-care when they're diagnosed with heart failure? Bonnie, maybe I'll quickly start with you, and then Sunny, you finish us off.
So I think it's the main things, right? Are you talking, Mark, did you say self-mental care or what?
Self-care.
Like
just self-care.
Physical, mental, everything?
I would look at both because I think they're both important.
Yeah, I do. So the big pieces, like I said, is around self-care is you need to give yourself a break. You're going to have your good and your bad days. And you just have to accept that. And all the self-management pieces, we could call that self-care. Make sure you weigh yourself, watch your sodium intake, watch your fluid intake, and make sure that if you are able, you can exercise, be it reduced ejection fraction or preserved ejection fraction. And really do understand that mental health is a huge piece of heart failure, and you need to speak up. Like, we talk about it more often than not now, and our providers have tools. They can use the PHQ-9 or the PHQ-2 to assess if you've got depression, and if you do, then you can get a referral. If you're in a smaller community, most nurses, most social workers, some OTs, they actually do counseling when it comes to depression, when it comes to anxiety. Providers can use the GAD-7 to assess for anxiety. So it is that holistic approach. It's about mind, body, and spirit, which is really important. But just give yourself a break if you have heart failure and know that every day is going to be different. Watch your symptoms and be a huge patient advocate for yourself.
Thank you so much, Bonnie. Sunny, any final words on that?
I don't know if I could do better than Bonnie. Bonnie did this well.
You're a great team.
If I'm going to add anything to it, like the self-care, I can echo it, but I think it's so important. And, in my daily life, even after post-transplant now, and now we're working and trying to live in your daily life, I think the importance of just kind of limiting stress and finding time for yourself to kind of get away and also to still be on your regimens. And it's okay if you kind of indulge sometimes, but to make sure that you're still just going back on track and following what your important regimens are, your medications. And I can't stress enough just being around the people that care for you, peer mentors, peer-to-peer support. Like I mentioned, these Facebook groups, and just talking to people and just overall looking out for your well-being. That's all I have to say to add to that.
Yeah, Sunny, I like the peer-to-peer support piece. We meet every Wednesday as a heart failure patient group, 2:00 BC time. And we have patients that dial in from across the country. And it is so mentally good for our patients. We laugh a lot. They give advice to each other and they keep me in line. And I love it.
Thank you both so much.
Yes.
Shannon, I'll hand it over to you to finish.
Great. Yes. Thank you very much. Thank you. It's really thoughtful questions and answers. Just a reminder that there is a recording of the webinar, and it'll be uploaded and available online on the following sites previously. And also today's webinar there will be an evaluation that will be sent to you by email, inviting you to complete an evaluation, and also a certificate will be provided. Other further resources, you're more than welcome to reach out to the Heart and Stroke and HeartLife website. And in addition to that, you are also welcome to visit the HeartLife Canada YouTube channel for an incredible heart transplant documentary by HeartLife. And then another additional resources you're more than welcome to see, and you'll be able to see this in the recording. And lastly, we do encourage you to visit the Canadian Heart Failure Society website for more information about the heart failure resources and events planned for Heart Failure Awareness Week. And on behalf of Heart and Stroke Foundation and HeartLife Foundation, we want to extend a heartfelt thank you to all of our presenters today and for everyone who took the time out of their day today to expand your knowledge and awareness of heart failure. We hope to see you very soon at Heart and Stroke's upcoming webinar in June, where we will focus on Stroke Month, women's mental health following stroke. Thanks again. Take care, everyone.